So I don't think it's fair to say, well, just do it. It's easier. It's like, what do you mean easier? $800 a month is not a sustainable way to approach medicine. It's going to bankrupt our country if we spend $10,000 on obesity drugs and $50,000 on fatty liver drugs, when even if 10% of those people were motivated and interested in lifestyle change, they need to be offered a way out.
If you've ever struggled with weight gain, with cravings, with this food addiction or this food noise and felt like your body was working against you and you couldn't control it, well, one, you're not alone, and two, you've probably heard of the GLP-1 medications, Ozempic, Wegovy, Mounjaro, that they're the revolutionizing weight loss and that they're the cure for obesity. Well, maybe you're already on one, maybe you're thinking about starting one, maybe you're a little skeptical about it. Well, clearly we need a more nuanced discussion and a more detailed discussion about these medications to better understand how to use them responsibly and successfully for the individual. And so today I'm joined by Dr. Mark Cucuzzella, who's a practicing family medicine physician, and Dr. Tro Kalayjian, who's board certified in internal medicine and obesity medicine. And I guess you could say they're on maybe the skeptical side of GLP-1 medications, but they're very thoughtful about the use and they understand that there's a clear use for them, but maybe not the broad use that we're all talking about or that so many people think. So here's this discussion to really help everybody, from individuals thinking about the medications, on the medications, or doctors thinking about how to prescribe the medications. Everybody will benefit from this discussion about GLP-1 medications. Well, Mark and Tro, thank you both so much for joining me today at Metabolic Mind. It's great to see you both.
Oh, absolutely. Great to see you. Two of my favorite people in the space. So having happy hour with you today.
It's an absolute pleasure.
Let's just open it up. And Mark, who is the best patient, the best type of patient that you think would benefit from a GLP-1 medication?
Yes, it's a great question. I think it doesn't have one simple answer, but it goes back to that full evaluation of why they're there. So in my practice, I actually have a clinic protocol before we would even bring up the medication. Let's make a diagnosis about what they have, right? So that would include basic lab work. Do they have sleep apnea? What's their fasting insulin? You can calculate a HOMA IR. What's their stress level like? Are they a night shift worker? What's their family history? So like what is going on to create whatever they might need or want that medication for? These are just the basics we would do even before we had GLP-1s. This was what we would do before we would refer someone to bariatric surgery. Are they food addicted? So, and that's, it takes time. I think if you're thinking you can do that in 15 minutes or over the internet with a telehealth, GLP-1 house, that's basically giving you the med with what's your BMI, here's the med. I think that's the wrong direction. But they need a good doctor. They need a doctor with experience, a clinician with experience. And I think we're all learning from every patient that comes in, but see where they're at. And then everything is shared decision making from there.
Yeah. So what you're describing, and what I love is that we're talking about good comprehensive care, right? Good comprehensive care first, and that's not really something that's done in modern medicine, in my opinion, on a systemic basis. And again, you hit the nail on the head. It takes time. Does that patient have a health coach? Does that health coach have empathy? Do they know what it's like to lose weight and keep it off? Do they understand the journey? Or are they a dogmatic sort of person, with dogmatic recommendations, right? So I think what you're describing is not necessarily the drug. It's, are people getting proper care before even turning to the drug? And this is what we've talked about before. It's my opinion that most people aren't getting the care they deserve before they're even offered a drug. They're offered a drug maybe because it's easier for the doctor, it takes less time, it has a very concrete and known efficacy profile. So it's very easy for the doctor, and it's very easy for the patient. It's just something they can do without necessarily having to address food or address exercise or address movement or address sleep apnea even, right? They can just take this drug. So I think, the problem is the way our medical system is set up, and not necessarily the drug. I
So
think
that makes total sense the way you explain it. But just to play devil's advocate here, the pushback is, well, whether you have sleep apnea, GLP-1s are going to help you lose weight and help your sleep apnea. If you have food addiction, GLP-1s might be able to help with that, right? If you have obesity and have failed other diet attempts before, GLP-1s are going to help with that, right? So people take the approach that GLP-1s can address all this. So just give the GLP-1. It's just so much easier. Like, so what's wrong with that? Like, is the patient still going to benefit?
so. Look, we published on this, right? We published on this earlier this year in February in Frontiers of Nutrition. We basically, looked at our 1 year weight loss results in one corporation, and the first corporate wellness program that we had, and the average participant lost just as much as the GLP-1, and they didn't have any need for any medication, right? And in fact, we took 5 patients off GLP-1s, and they kept losing weight. So it's not that it's not easier. I mean, look, it defined easy, right? That's an $800 to $1,000, per month, whereas our program is a fraction of that. I'm not saying that one is right or one is wrong. There are some patients that truly cannot take the time, don't have the insight or the ability to implement a lifestyle change. But I don't think most patients out there have access to a program like ours, have access to a program like Verta or ONA. They've never even gotten the basics, right? They're used to waiting 2 hours in a waiting room and seeing a doctor for 7 minutes and being given a prescription. So I don't think it's fair to say, well, just do it. It's easier. It's like, what do you mean easier? $800 a month is not a, sustainable, way to approach medicine. It's going to bankrupt our country if we spend $10,000 on obesity drugs and $50,000 on fatty liver drugs, when, even if 10% of those people were motivated and interested in lifestyle change, they need to be offered a way out. And here's the last point I'll make, and I'll keep quiet. There was a recent study showing the real world results. Our study was a real world sample, right? This is what happened in the real world. When you look at the real world results for the GLP-1s, they're half as effective. It's about a 10% weight loss. It's not the 20% from the clinical trials. So if you compare apples to apples, we're double as effective, right? For a fraction of the cost. Now, the last point here, and I promise I'll be quiet, is so many people can't tolerate these medications due to nausea, vomiting, diarrhea, constipation. So we have to understand that these are easy in the short term. These are easier, quote unquote, in the short term. And all of these issues, we're seeing it in our clinic every day. The quote unquote, people don't respond or couldn't tolerate the medication. So, if we're just kicking the can down the curb, these are amazing drugs. I'm not going to deny that. But I think we have to think bigger picture if we're really talking about making America healthy.
Yeah, now just to tag on Troy, you made a couple really important points. So all of the clinical efficacy trials for other comorbidities, whether it's cardiovascular, sleep apnea, osteoarthritis, the patients who achieve those benefits have lost significant weight loss, 10 plus. So we can't say it's a direct medication effect. If you lose 10% of your body weight, your sleep apnea gets better. And we knew that before GLP-1s. But kind of just to frame it like this, I think the world now is always it's kind of in this bi-direction, bipartisan, we're always either or, but it's kind of yes and type of phenomenon. So let's take medical assisted therapy or treatment for alcoholism, right? So we have medications that help those conditions, help people stay clean, stay on track. But that is not the treatment. The treatment is what Tro does. The treatment is the support. The treatment is treating the food addiction. If we gave someone Suboxone for their opiate use disorder, we don't expect that. We don't give that out in the ER without a support system thinking, well, it works for that. No, they need a comprehensive program, whatever that is, tailored to them. And in some patients, we see some patients come off of Suboxone. We see some patients come off of naltrexone for alcohol use disorder. Some need to stay on it forever. Some don't need it at all once they get in the program. So it has to be the foundation of the treatment is not the med is not the treatment. The treatment is the treatment, the comprehensive care that they get that's tailored to them, which takes time and takes the right team to do that. And yes, the medication in the right person can be a very powerful adjunct if those other things are in place.
I want to answer the question because I think we're in 100% agreement. When we look at medicine historically, doctors are so terrible at prescribing medications. We need insurance companies to tell us, prescribe this, don't prescribe that. We need antibiotic stewardship programs so we don't abuse antibiotics. If there's anything that tells you something about the doctor culture, it's that we turn to medications too often and too quickly and too soon and without enough thought and consideration. If you look at what's happening with the controversies over long-term SSRI use, right, and withdrawals that they lead to, these are all topics that we need to address. And the main issue that I think is coming out with the GLP-1 is not the drug per se, because all the drugs I mentioned have the right patient, which was Brett's question. There is somebody who will benefit from, somebody with severe depression and suicidal thoughts that may benefit from SSRIs. There's somebody with sepsis who will benefit from antibiotics. There's somebody with intractable food addiction, with risk of heart attack or risk of limb amputation, with roaring diabetes, that's going to benefit from a GLP-1 drug. I think that is the beauty of medicine and beauty of science, is that we have these tools. So the issue is not the drug, it's the culture, right? And it's our culture, it's the physician's culture. So I think, and we've just started this in our clinic, we need stewardship programs over these medications, because it's not appropriate to have advertising on Super Bowl that this is the cure to obesity and this is the fight that every patient needs to make. I don't think that's appropriate at all. And, literally these companies have thousands of patients within 15 minutes getting a prescription. And just as a point to make, I went on Weight Watchers Clinic and I put in that I had a family history of pancreatic cancer, pancreatitis, and thyroid cancer. And they said to me, right, that I was a candidate for the injection weight loss medication, right? So, and now they're, going through bankruptcy, and I don't, but this is the problem. But to answer Brett's question, who's the right patient? Somebody I just described, maybe somebody who's facing, who is high risk of a 20% 10-year cardiovascular risk, somebody with diabetes on insulin therapy, unable to come off insulin therapy, somebody who's made a good faith effort in a comprehensive program to make lifestyle change possible, somebody who's engaged in a program and, life has thrown them lemons. I think those are the people that need to consider it. If the risk is high and the patient wants it, right? The patient understands the unknown unknowns of long-term side effects. So that's the answer. And I'd love to hear, Mark, who you think, is that right patient in your opinion.
Yeah, and I've shared some of our handouts that we use in the clinic. So 6 months of full-on lifestyle therapy, treat the sleep apnea, treat the stress. So fix the diets, get them on low carb, high protein, all the things we knew to be true, we still know to be true pre GLP-1. So do that just like you wouldn't refer someone for a gastric bypass at your first visit, right? You're going to do everything you can to help them, get them the right comprehensive care, treat their food addiction. Now, some people struggle, like and I kind of see it like this in my clinic. It's kind of a third. A third of people, it's like, oh, I love meat, and they weren't obese at age 18. So I think there's a huge genetic factor or epigenetic. These kids who were 400 pounds at the end of high school, and Ben Bickman talks about the adipocyte hyperplasia. These folks are in a different world. So that history is like critically important. And then who's gained the weight, after the 30th birthday when they went through a divorce and they started working night shift, and they know all the bullet that came at them, and they can reverse that. So 6 months, full comprehensive care. How are they doing? I love meat. I love eggs. They never look back. And Tro and I have both seen people lose 100 pounds and they never look back, and they feel like $1 million. They drop all their meds, but that's not everybody. And then you have a third that are, going through a divorce, lost their job during the pandemic, kid just got in trouble with the law, financial, like, and they're just like quitting smoking. They're not ready yet. They can't, and they're not ready yet. Then you have the third that struggle, right? Like, and Tro, you've probably seen these folks, like, they understand the diet. They understand every bullet coming at them, but they just can't, they have a lapse and a relapse. Like, they're constantly struggling. They can't get the food noise out of their mind, but they understand it and they're struggling. They're not weak. They're not lazy. They're not gluttonous. They are trying. And in every other medical condition that involves human behavior, we never blame the victim. No, we have treatment for that, right? So, and you think alcoholism or substance use disorder. No, this is your own moral weakness. Just get over it and get off this stuff. No, we have a duty to treat those people. No, it doesn't need to be GLP-1. We have other weight loss meds. We have naltrexone, we have bupropion, we have phentermine. We have other things that aren't quite as potent in the big picture research-wise, but yeah, so you can start people. We've tended to forget about other obesity meds, and there was a very interesting study on off-ramping GLP-1s by colleagues in Vanderbilt that showed that you can off-ramp the GLP-1s once they've kind of fixed all that insulin resistance with that year of GLP-1. Now let's get them onto another lower-cost generic anti-obesity med, and they continue to lose weight. So sometimes you got to go in early hard, right? It's like Atkins induction, right? You got to fix the problem hard early to fix the insulin resistance, and then you can kind of back down versus like trickling into it and always fighting upstream, right? So we know historically that works, but so that's kind of the approach, is that middle third that need help. And I've seen it in plenty of patients. You give them minimum effective dose of GLP-1, not just crank the dose on autopilot, minimum effective dose, keep doing what you're doing. And I've seen people, you see their weight curves, boom, and they're like, "Doc, something happened. Like, I shut it off and it works." I mean, have you seen, some patients like that? Individual results may vary, with everything we do, but have you seen some of those, Tro, that like really are doing it right and they're just struggling, and you get them on a little bit, something works?
Unfortunately, I'm seeing the opposite, which is I have a clinic full of people who've been on the compounded version for for over a year. Yeah, I'm seeing the quote unquote failures and non-responders. I have a clinic full of failures and non-responders. So I see the efficacy. I see that, like, I'll tell you, we've seen the patients come off insulin. Like, I've had some people with severe insulinopenia who are on insulin for 20 years, just need a tiny bit of metformin and a tiny bit of GLP, and they're off insulin, and they're doing the diet great. So I've seen some amazing, amazing cases, but a lot of these patients have already been set up to fail. They had bariatric surgery, they had the lap band, now they're on the GLP-1, and unfortunately, I think you and I know this all too well. They're being set up to fail. They are, they're not like their doc. We know that 1/3 of the weight lost with these medications is muscle, right? How many of the people being given a prescription have their doctor helping them or have somebody helping them preserve muscle, right? How many people, right? It's a known side effect. Every single doctor out there knows that 25 to 35, maybe 40% of the weight, Ben Bickman says 50% of the weight is muscle. How many people have protected against this known issue, by helping their patients get a minimum amount of resistance training? How many have, and look, we know that when this medication stops, that the rate of weight regain is twice as quick as diet and lifestyle. So how many are saying this to their patients that, hey, I'm starting you on this medication, but if it's no longer effective, or if, you can't tolerate it, the rate of weight regain, I mean, think about the psychological impact of failing the miracle drug or being set up to fail.
Yeah, you're talking about medical ethics, right? There's no shared decision making, informed consent.
Well, yeah, I mean, how can you have informed consent when someone someone comes in because they saw the commercial and they say, I want that drug and I just want it. I don't care. I just want it. Yeah. Yeah, but so okay, so we've talked a lot about sort of the concerns about the drugs and the downfalls of the drugs, which are many, but despite that, there's still, even for doctors who believe in lifestyle, there is a clinical use for it. It seems like so Mark, you talked about starting at a lower dose to help people in that way rather than give them the highest dose. So just give us an example. What are some of the low doses? Not that you're telling anybody to try this and this isn't medical advice, but just in your clinic, what are some of the low doses that you've seen and what's the number one effect that you see from that?
Yes, I mean, I'm using FDA prescribed medication. So starting dose of semaglutide is 0.25, injected once a week. Of tirzepatide is 2.5, and they come in pens, auto inject pens. So stay there for 4 weeks, maybe even longer. Now, the patients that struggle with the low dose, we know that hyperglycemic patients, it blunts the effect of GLP-1. So the more metabolically broken someone is, they're probably going to need a heavier push. So someone who's got an A1C of 8, say they're on insulin therapy, it's likely going to take a little dial up, but you have to work through the side effects. But in that first 4 weeks, you can, because you don't titrate the dose quicker than any 4 weeks, 4 weeks for side effects. So you can do a lot to their brain in that 4 weeks. You can do a lot to their gut, fix the gut microbiome. I have a handout sitting right here, a gram of protein per pound of ideal body weight, hit the gym, maintain, preserve your muscle mass, treat your sleep apnea. How are they doing? And the goal was just to keep them there. We never really thought about cranking that dose up, but just like any pharmacologic product, you develop tolerance. So if I saw a prelim study of 7.2 milligrams of semaglutide in a study. You're like, what the heck? You just keep cranking it up, and then they become almost, we talk about more insulin, more resistance, more semaglutide, you're going to become semaglutide resistant, right? And then you come off it and you've been holding this beach ball underwater, so to speak. It's going to be much harder to off-ramp someone from 2.4, than someone who was on 0.25. That person's an easier off-ramp because they've already made the change and they're only on just a little bit of the med to maybe affect that central system, which we know that GLP-1 is produced in your brain. But the GLP-1 injections are long half-life, where the GLP-1 produced in our gut is a very short half-life. So that's kind of the magic, is this long half-life that can control their appetite.
Well, let
But
me
that's how I
transition.
use it.
Yeah, so let me transition to you then, Tro. So you talk a lot about food addiction and food noise, and that's come up a couple times already. Do you see a role for these medications in helping to address that specific component of obesity?
Undeniably, they improve food addiction and binge eating. Okay, undeniably. I'd say they're probably the single most potent medication out there, even more potent than the amphetamines used in binge eating, like Vyvanse, and it's much more potent than even gastric bypass. Just of note, when you're doing a sort of a systemic analysis of all the different therapies out there for food addiction, a caloric reduced diet results in no improvement in binge eating or food addiction. Absolutely none. So, and we just published today, well, maybe when this is out, it'll be, in the past, we just published roughly a 40% reduction in symptom severity with a ketogenic diet and a social support network, which is just like on par with the amphetamines and slightly less than the GLP-1 drugs. So absolutely they help on the brain, right? The 100%, but you don't need a high of a dose, as Mark said, right? You can, if you have the Ozempic pen, you can titrate the clicks. Like you can do 1/10 of the dose with 2 clicks, right? Just to see, how does this thing affect my brain? You may need just 2 clicks, right? So there's no harm in doing less of a dose and seeing if you get, and if it doesn't work, you of course you titrate up, and I think we're going to find out soon. And this is just my guess. This is me making clear my assumptions. Just like with bisphosphonate drugs, when we put people on holidays, right, because of the side effects, I'm fairly certain we're going to do the same thing with these. I would be if I had to predict, I'd say after 2 years, taper and stop, take a holiday, and then reconsider use later on. So I think the lowest dose possible, or if the stakes are high, I like to ramp up quick and then ramp down quick.
And what do you mean by stakes are high? Give us an example.
Yeah, somebody who's going to face an amputation, or took a wound that didn't heal, or has a significant soft plaque and hard plaque burden in their heart. We know their cardiovascular risk is through the roof. Somebody where the stakes are really high. If the risk is high, I think I'm more apt to crank the dose up and then taper off quickly. Because I'm using it. It's sort of like with sepsis, right? Like you throw somebody, if somebody's severe sepsis, you want to get them antibiotics early, an effective dose, make sure you do comprehensive care, give the fluids, monitor the pressure, and then you sort of figure out everything, later on, and take them off the drugs later on. I suspect it's something that's the way I use it. When I use it, I'll start like gently, see how the body reacts. And then if I really need it, because the stakes are high and that patient is at high risk, I'm going to go to high dose fairly quickly.
Fellow mental health clinicians and healthcare providers, you now have access to a suite of free CME lectures on metabolic psychiatry and metabolic health. Each of these CME sessions provide insight on incorporating metabolic therapies for mental illnesses into your practice. These CME sessions are approved for AMA Category 1 credits, CNE nursing credit hours, and continuing education credit for psychologists. And they're completely free of charge on mycme.com. Now back to the video. Okay, that makes sense. Now, so you've also talked about, coming off the drug eventually at a year, whatever the case may be, coming off the drug or tapering off it. So for both of you, what if someone comes to your office, they're a new patient? Oh yeah, I've been on this, I've been on Mounjaro for 6 months. I feel great. I've lost weight, super easy, love it. What do you do? What are the 3 things, for each of you, what are the top 3 things that you will say to that patient to say, well, maybe we eventually want to get you off, and we can do that by doing X, Y, and Z? What's on your list?
Yeah, my first one is, are they healthy? So if they're back to, BMI could be varied depending on their muscle mass. So are they healthy? Yes or no? So if they're healthy, that's a good start point, right? Like Tro saying, someone who's not, they're still diabetic and about to lose their foot, they're not ready to come off. But if they're healthy, by every parameter that we would say, right? Their blood pressure's better. They still have cardiovascular disease, but it's stable. They're fit. They're strong. And then what's their confidence? Do you want to do this, right? Shared decision making. Look, I think you're ready to come off this med. You have fixed your metabolism. You have fixed your brain. So get their buy-in. They're captain of the ship. Patient's autonomy, right of refusal. So yeah, I would like to, and I would suggest certainly like coming off any medication that is not a lifelong medication. So we've been told that these are lifelong medications, but that's not true. Right. So you fix the problem. And just like we know diabetes meds are not lifelong meds now, even though we were taught in medical school they were, we know that that's not true. And then what non-negotiable things are you going to do you can spread the dose, right? So say they're on a low dose, just space it out, take a holiday. Let's do this. There's no harm in holding the med, but they have to have kind of ownership and they have to want to do it. And if they have confidence to do it, and we give them confidence, yeah, you can do this. You're just their coach. Look, I know you can win this game. And they have good odds of winning the game. If we say there's no way Tro, your kid's team's going to get crushed today, and you tell the kid that in the car as you're driving to the game, what are their odds of winning the game? It's like 0. The human brain is so powerful when it wants to do something. And I don't never discount that if they want to do it. But that's I don't know. I mean, that was about 3 things.
No,
So
those were 3 things. I mean, really important to make sure they're healthy, not just that they've lost weight, but that they're healthy and that they can come off and that they're ready for it and that they can buy in and that they really think they can succeed. I mean, those are 3 really important things. So assuming we have all those, Tro, what are the practical next steps to say, here's what you got to do?
I'm going to reemphasize, I so much agree with Mark here. Does the patient want it? Like one of the biggest concerns I have is I may have values, right? I want to deprescribe the world. I want to get the entire United States off drugs that they don't need, right? But at what point do I draw the line? Am I imposing my values on the patient? So assessing readiness to change is huge. But pragmatically speaking, which I think was the question you were asking, it's, the best data for deprescription and safe tapering of these medications is, exercise, right? Resistance training and low carb diets, right? So, using biofeedback, using a coach, can they maintain a diet? If they can, right? If they're still struggling with these drugs, if there's glycemic variability on the drug and they're stressed out and there's a hurricane and they lost their job and they're having a divorce and they're not ready for change, and you were dogmatic in your approach because you had a glorious ideal of taking on off a drug, I think this is a setup for failure, right? So I think it's so important to be introspective as doctors and make sure that we're not implying, putting our values on the patient, that they're ready for change and they understand the stakes. I'm taking away this crutch. Are you ready for this crutch to be taken away? And, like Mark said, if the vision is there with them and it's their vision that you're executing on, then it's going to be a success. But if it's not their vision and it's our dogma, this is a setup for failure.
Yeah, I think that's a good point. And one of the amazing things about you, Tro, is how you publish your practice results. And these are people who may be ready, may not be ready, but they go through your program and they achieve amazing results with the coaching and with the keto diets. But I would imagine that the majority of those people seek you out for that reason. So, Mark, you have sort of the opposite of that. You see anybody who walks in the door for any reason. They're not coming specifically to see you for a low carb intervention. So if you're going to use a ketogenic diet and exercise to help people get off the medications, how successful is that in just a general population of primary care?
Yes, we're about to publish VA data for 12 months. So about 90% of the patients that were on diabetes meds, we were able to reduce them. So that's pretty good in the real world setting. So, I feel there's an important message there. Like primary care, this has to happen in the family doctor's office. Now, if we had a million of Tro out there, the world would be good. But he's a unicorn. He's like, people got to find him. But like everyone has a GP or family doc almost around the world. And so if we don't have enough obesity specialists to deal with the 40% of the population with obesity and the 60+% with prediabetes and diabetes, right? So we can't refer these people out. And most of the time when we refer them out as primary care, they go to the medical model, right? So they'll go to pretty much traditional medical care, and that has not been shown to reverse disease. So, I want to teach primary care doctors that they can do this. And it brings them joy. So when I see someone come back and they're feeling better, that makes me want to go to work. It's like, that's a good visit. If they come back and it's like, well, your cholesterol is worse and your diabetes is worse, we need to increase your insulin, we need to add a statin, we need to add 2 more blood pressure medicines. All the admins are happy because you're meeting all the check boxes, but I'm not happy. The patient's miserable. And like, we failed, but the system's happy, that everyone's getting paid. I hate to put it that way, but that's in Western medicine, we get paid by the more we do. So we have to turn the model upside down, which is what, Tro is doing with Toward Health. It's like, let's value getting people better and let's get paid for that value, right? So you're saving the system money, hire the right people to make this happen. But yeah, go ahead, Tro, on your thoughts.
Yeah, I'm just so many thoughts happened here. One of the biggest ones is, Brett, I thought the only reason my only value is because patients are ready and they're coming to me because they know what I'm doing. And it was a lot of patient self-selection. When we went out, now we've done 10 different corporate environments. And what I found is has nothing to do with that selection. Well, I shouldn't say that. It has to do with dual self-selection, right? They don't know Tro, in Louisiana, right? But what we're doing is we're screening them and they're screening us. So we're saying, hey, do you want to get healthy? Do you want to come off medications? Do you want to reclaim your life? And they're choosing to enroll in a program. So what it's doing is it's directing resources to the people who are ready to implement lifestyle change. And then our goal as a practice is to keep that and to maintain that over the number of years.
So with the stewardship of GLP-1s, I mean, it sounds like if you're going to start the medicine, a plan should also be in place on how to get off the medicine, but to have that sort of baked into the prescription almost. And so is that sort of what you mean by stewardship, to have that say, all right, here's how we're going to use it. We're going to use it judiciously, and we're going to put lifestyle plan in place that is going to make it hopefully unnecessary in the future.
Look, I mean, like, look, if you just gave them a handout, right? Like, we know that low carb diets, exercise, community and support work, right? We know that community support work. We know that biofeedback works. We know that, you know, the continuous care model, access to coaches works.
Stewardship, Brett and Tro. So, I've talked about these meds should be in some way controlled substances. So it all kind of went rogue when they became obesity meds, and somewhere along the line, like 30% of people getting these drugs now don't even meet FDA criteria, right? So like in West Virginia, everything has to go completely off the rails before we step back and say we have to try to put the genie back in the bottle. So these meds are being used right and they're being used wrong. So if there's an audit, and here's, Dr. Schur in California with his practice, and he's giving out GLP-1s, dozens and dozens and dozens of prescriptions a day. I mean, like that was happening with opiates. People were giving out, 120 prescriptions a day. Wait, how is that? Like, who are these people? Yes, I know but it was happening, right? They were coming in. So somewhere, because it's breaking the bank of the economy for one, but it's also harming a lot of patients. So if you're getting a medication that can cause harm by a doctor, and it's not FDA approved, and there's not informed consent and shared decision making, and I prescribe that, I should not. I took an oath. I should not be allowed to do that. But it was happening a lot and might still be happening. But I think now that the compounding is shut down a bit, that it's not happening quite as much. But there's not any check and balance on, like how many prescriptions have I given this month? I get a report every month from the DEA about my opiate use. So if I was red flagging, they would be on me in a minute.
No, but that's a great point though, because if the discussion is, well, these drugs are miracle drugs, right? Think about the terms people have used for these medications. They're miracle drugs. They're the solution to obesity, right? They're gonna cure the obesity epidemic. These are the messages that we read on a regular basis. So you can see why people would just be prescribing them, and people wouldn't question it if that's what's in our brain. So I think these are the discussions people need to hear more of. They need to hear you, Mark. They need to hear you, Tro. They need to hear the responsible use of these medications and what other options are there. So hopefully this interview, this discussion here will help further that movement, so that we can sort of change our perspective around these medications. Not that we want to throw them out and not use them, but if they can be used appropriately, we can really focus on what's going to make people healthier in a sustainable way for the individual, for the country, for the world. So anyway, that's my soapbox, but thank you both for joining me. And I'll give you actually each a moment to let us know where we can follow you to learn more about you. So Mark, why don't you start?
Yeah, I'm not on social media much. I'm kind of a hermit working up here in Maine right now, but I have a website, Dr. Mark's Desk. If you're in my hometown in West Virginia, I have a little running store. So it's called Two Rivers Treads. So you can start walking. Walking is magical medicine for every part of our health, and running too, but just get yourself outside and in the parks.
Great. Tro?
Yeah, Toward.health is our clinic. There's a free app, Toward Health. Podcast is Low Carb MD Podcast. Look, we are trying to help every company out there. We're certainly care about individuals as well, but we're really focused on the companies because we can offer our services for free through company-sponsored programs. When we save the company money and get their employees healthy, they're paying for it. So that's hopefully you'll find me in your HR department. That's hopefully where you can find me. And it's just an honor to be here with two people that I really look up to. So just want to put that out there.
Thank you. Well, thank you
both
so
back
much.
at you. Appreciate what both of you are doing. A lot of respect.
All right.